A professional counselor in the Dallas area is growing in popularity for his treatment methods.
How do you talk to kids about terror? And with social media and television, it's everywhere, and it's unavoidable for kids.
Rusty Lozano is the founder of the Center for Biofeedback and Behavior Therapy. He's also been nationally recognized for his work with brain mapping.
He's created a gym to work out the mind. His office features an obstacle course.
Rusty Lozano is a licensed professional counselor, helping children with headaches, with anxiety, ADHD, and more.
Here's where Lozano comes in. He teaches kids how to think their pain away with something called biofeedback.
A North Texas therapist is treating patients in this unconventional way.
We have Rusty Lozano who's joining us today. He's a licensed professional counselor.
He put together an unusual treatment for teenagers who are struggling with mental issues, except he's taking this now a step further.
Rusty Lozano, a leading therapist and pediatric biofeedback therapist based in Texas at the Center for Biofeedback and Behavior Therapy. And Rusty, thanks for being with us tonight.
Rusty Lozano, a father of 4 and also a professional counselor in Texas, says it's all about being a credible resource to your children.
The Therapy Hour with Rusty Lozano, your dedicated resource for mental health news, views, and tips you can use. Brought to you by the Center for Biofeedback and Behavior Therapy in Addison, Texas. And now, here's Rusty.
Hi, good afternoon, and welcome to the Therapy Hour. The show is brought to you by the Center for Biofeedback and Behavior Therapy in Addison, Texas. I am your host, Rusty Lozano, and today we have an outstanding show. We're going to be talking about depression and suicide with Dr. Joel Holliner Well, let me tell you a little bit about who he is. Dr. Joel Holliner, he's board certified in psychiatry and addiction psychiatry. He's the executive medical director at Green Oaks Hospital, chief psychiatry at Medical City, Dallas Hospital. He's in private practice at Medical City in the Holliner Psychiatric Group, specializes in psychiatrics, medication management, and hospitalization. We'll have him on in a second, but let me introduce our topic. Depression and suicide tend to kind of go hand in hand in some circumstances, not always, but we're seeing it a lot more prevalent with our soldiers, our PTSD infected soldiers that come back, and I'm learning a lot more about this from organizations called 22 Kill and other organizations that try to help these individuals. But it doesn't necessarily have to be somebody who is experienced, trauma from the services. Let me kind of give you a generalized explanation of depression from the National Institute of Health. Sadness and grief are normal human emotions. We all have those feelings from time to time, but they usually go away within a few days. So sadness and grief is a normal emotional state. Major depression is something more. It's a period of overwhelming sadness. It involves a loss of interest in things that used to bring pleasure. Those things are usually accompanied by other emotional and physical symptoms. Untreated depression can lead to serious complications that can put your life at risk. Fortunately, those people can be effectively treated. And then let me give you this other statistic here about the prevalence of it. In the National Institute of Mental Health estimates that in the United States, 16 million adults has had at least one major depressive episode, and this is in 2012. That's 6.9% of the population. According to the World Health Organization, WHO, 350 million people worldwide suffer from depression. It's a leading cause of disability. Data from the National Survey of Drug Use and Health highlights the problem among young adults from 2013 to 2015. More than 8% of young adults between the ages of 18 and 22 reported a major depressive episode in the previous year. When it comes to gender, women are more likely to be diagnosed with depression than men. So let's jump right in and talk to Dr. Holliner. Dr. Holliner, welcome to the show.
Thanks so much, Rusty. Great to be here.
Yeah, thanks for coming on. I really enjoy having you. You're always very insightful. Dr. Holliner, what are the types of depressions that are out there?
Well, there's a lot of depression, and just by having depression doesn't tell you that much because, as you were mentioning, depression is a symptom. So everyone has depression at some point in their life, or almost everybody. I guess there's a few people that are happy all the time, no matter what, but that would be very rare. So it's part of the texture of life. Let's put it that way, to be down sometimes.
It's a normal human emotion.
Absolutely. So it's not necessarily an illness, and we psychiatrists, don't want to treat anyone that's depressed for a little bit and having a rough time with the situation. That doesn't mean that you jump in there and give them medications or try to put them in a hospital or whatever. That's normal. But there are other areas of depression that become more problematic. There's women that get depressed after they have children. It's called postpartum disorders. And those folks, they need to be treated because they are very likely to have problems bonding with their baby and being as good a mother and having the kind of relationship you want. And those women are more likely to have more serious illness.
And those complications typically are neurochemical. I mean, it's not that the postpartum has nothing to do with like the separation of the child from the female, but is it a neurochemical imbalance? Is that what's happening?
It's probably postpartum is probably due to neurotransmitters in the brain that change, but also different hormones that change, and it's stressful having a baby. I mean, it's wonderful, it's fantastic, it's exciting, but it's also. I remember my wife talking about it after we had our first child, and she said, "I got so much attention when I was pregnant, and everything was neat. It had its moments where it was a little challenging being pregnant in the Dallas heat, but basically it was a lovely experience for the most part. And then I had my baby, and as great as it was, suddenly I've got this baby to take care of. It's changed my whole life, and I don't get quite as much attention as I did, and I just go to the doctor every now and then instead of very often, and then and giving me lots of. So there's lots of changes that occur after.
That's interesting. I never really thought about that. But my wife, she said a very similar circumstance about staying in the hospital for her pregnancy as well, because it was just a push of a button, and anything that she needed, and she was comforted, and she had the help and support, and she got sleep. Which is kind of a rarity here in the beginning.
That's right. Sleep deprivation contributes to it also. Yeah, so absolutely. There's a lot of factors that contribute to postpartum.
Absolutely.
And there's many other kinds of depression too. There's something called adjustment disorder. And adjustment disorder means that there's a stressful life event and that we have some symptoms of depression, anxiety, and so forth, but we can work through them. Generally, maybe we need to see a counselor. Maybe we need to get involved with biofeedback. Maybe there's other kinds of treatments, but generally we don't think of medication for that kind of depression. But then there's a depression where it's been going on for weeks at a time, and you have either a loss of interest in things you used to enjoy, or just you feel down and blue, or both, very often both, and lots of other physical and emotional symptoms, crying spells, hopelessness, appetite changes, sleep changes. And when you have enough of those symptoms that have been going on, that's when it's called a major depressive episode, major depressive disorder. And those are the people that need to be treated with medication and often psychotherapy too.
And those are pretty major life-changing events. So you think about pulling away from things that have made you feel happy, and your appetite changing, and your just sensitivities and mood swings and mood changes. I mean, that's changing the fabric of the kind of person that you were.
Absolutely. It's a very serious illness, and it's not one that, we don't take the Ronald Reagan approach to mental health, pull ourselves up by our bootstraps like we used to think in the past. Now we realize it is a medical illness that needs to be treated. Family doctors are becoming much more aware of that now, and most depression is treated by the family doctor, by the OB-GYN doctor, by the internal medicine doctor, the family doctor. Not that many of those patients come directly to a psychiatrist because it's so common. It's so incredibly common.
What are the family history components? Is depression something that is hereditary?
It does tend to run in families, Rusty. Absolutely. It's thought that about 50% of depression is related to genetics. When you look at twin studies, you have twins and you raise them in two different homes, separate at birth kind of thing, and you find that they're twice as likely as the general population to be depressed, if one is depressed for the other one to be depressed. So there definitely is a genetic component to it. But there's also other components to it, life stress, things that happen when we're growing up that set us up. So there's I view it as three different factors that lead to depression. There's the genetic material, what we inherit, which is certainly a big factor. And then we get into things that happen to us when we're growing up that may make us more sensitive to life stressors. That happen. Like an example of this was I had the first patient I ever had as a psychiatric resident that was assigned to me, a lovely woman who was 27 years old, a legal secretary, and she came to me. She was terribly depressed. And it turns out that she had a sister that was terribly depressed. So I say, oh, you got the genetics. I see that. Mm-hmm. And I was trying to figure out what happened when she was young to see if there was something that set her up for depression. And I learned that her father had abandoned them when they were very little. Mm. And then what recently happened was her boyfriend broke up with her. And that was just overwhelming to her. So she had the genetic propensity. She had the early life situation that set her up for loss, a certain kind of stressor being hard on her. And then she had that stressor that all led to depression.
And that was a triggering mechanism then, the breakup,
absolutely,
the separation, that kind of brought her back to square one. And so then she started to experience those symptoms. It's like it was a triggering mechanism.
That's right. So that's why very often we will recommend for depression a combination of medication and of talking therapy or psychotherapy to help along with that.
And the combined approach is really effective. We're going to talk more about this as soon as we come back from a commercial break. We're visiting with Joel Holliner. Stay tuned. We'll be right back.
Policies issued by American General Life Insurance Company, Houston, Texas. Not available in all states. For details, visit AIGdirect.com.
Do you have a family? Would you like to help make sure they'll be taken care of if anything were to happen to you? If you answered yes, you probably need life insurance. Now, do you think life insurance is expensive? If you answered yes to that too, you definitely need to give AIG Direct a call. We could find you a $250,000 policy for just $14 a month, which means you could save hundreds of dollars a year. Call us now for a free, no-obligation quote. 1-800-400-3816. Since 1995, we've helped millions of people find out if they could save up to 70% on their term life insurance. See how affordably we can help you protect your family. Call AIG Direct now for your free quote. 1-800-400-3816. You could save up to 70%. That's 1-800-400-3816. 1-800-400-3816.
Have you ever considered weight loss surgery? At Faith Bariatric Success Center, they can help. If you've ever thought about weight loss surgery, call pound 250 from any cell phone and say Faith Bariatric to get more information. Now offering free consultations. Pound 250 and say Faith Bariatric.
Do you think identity theft is only when someone adds charges to your credit card? It's actually when someone pretends to be you to open new accounts in your name or any number of bad things. LifeLock can help. We use proprietary technology to alert you to a huge range of identity threats. And if you have a problem, we have a team of U.S.-based specialists who will work to fix it. No one can prevent all identity theft or monitor all transactions at all businesses. Membership starts at $9.99 a month, plus applicable taxes. Go to LifeLock.com and use promo code NEWS to get 10% off.
When is the best time to talk to your family about staying in touch during a disaster? When floodwaters reach your door? When wildfires are engulfing the edge of your neighborhood, or an earthquake is destroying buildings. When a tornado is tearing through town, or a hurricane strikes. Or is the best time perhaps today? During a disaster, you may not be able to stay in touch with your family or friends as easily as you think. And it's not always as simple as using your cell phone. That's why now is the time to take action. Go to ready.gov/communicate and make your emergency plan today. Don't wait. Communicate. Brought to you by FEMA and the Ad Council.
From the Talk Radio 1190 Weather Center, this report is brought to you by Key Whitman Eye Center. Today, it looks like we're going to have partly cloudy skies with a high around 102 and a 20% chance of rain, but I doubt that happens. And tonight, clear skies with a low around 82. I'm Will Shotwell with your DFW weather.
Tired of contacts and glasses? Right now, LASIK is a hot $99 a month and you get $1,200 off. Only at Key Whitman for a limited time. So call now, 214-220-EYES, or visit keywhitman.com.
You're listening to the Therapy Hour with Rusty Lozano, brought to you by the Center for Biofeedback and Behavior Therapy in Addison, Texas.
Hi, we're back, and thank you for joining us. If you're just joining us, we're talking about depression, and we're going to be discussing suicide with Dr. Joel Holliner. He's with the Holliner Group and board certified in psychiatry and addiction in psychiatry. Dr. Holliner, we were talking about family history. Is there genetic testing? Let's talk a little bit about that. You'd mentioned genetic testing.
Right. Well, unfortunately, there's not sort of dipstick psychiatry. It'd be great if we could just do some blood test to see if someone was depressed or if they were likely to get depressed. So we're not there yet. Mm-hmm. But what we do have is genetic testing to help us evaluate the appropriate medications that can be used for depression. And we are doing that in our practice where we'll do genetic testing, and other medical specialties are also doing genetic testing. And it's fascinating because you can do that and look and see how a certain medication might affect someone. It doesn't tell you whether it would work or not, but it tells you if you need a higher dose, a lower dose, if it likely would be ineffective due to the metabolic breakdown of that medication.
So I've heard of this, and they can actually find out, they can tell you what kind of medications work well with with your DNA. I mean, with essentially how your body is set up. Your body
it is
chemistry.
A DNA test, Rusty. It's amazing. They go in, they can do a blood test, or in our office we do a cheek swab test, and they get genetic material from the cells in your cheeks, just swabbing it, and they can run this test, and it's absolutely amazing. And this is being used in all kinds of medical specialties, used in cancer treatments now, used for other disciplines. So it's the wave of the future.
That's phenomenal. That really is. I've totally heard about that. I've even heard of families going to get this kind of testing for ADHD to kind of find out what kind of medication works, best with their bodies, and really, really interesting stuff. What are some other evaluation and treatments that you guys actually? How can you further detect depression?
Well, what we do is we get a patient that comes in, and typically they'll come in for an hour for the first visit, and we go through the entire history. We go through family history because we said things run through families, and if it's positive, what did a family members respond to medication or treatment-wise? Because since the relative has much of the same genetic material, that might lead us to a certain direction in treatment. We look at the entire history trying to rule out a bipolar disorder, which is another kind of depression. Bipolar disorders, you not only have the downside or the depressed side, but you have periods where you have enormous energy. It's called a manic episode.
Yes.
Where they're talking a mile a minute, big plans and schemes, moods elevated, don't need to sleep much, and very grandiose or hyper-religious, and those sorts of folks. So we want to see if there's any episodes of those in the history. And so we just go through the entire history, medical history, to try to come up with a good diagnosis. And also to see if they've been depressed before, what has worked and what has not worked medication-wise.
Right. I mean, because I'm sure that it can be really difficult to try to figure it out. Most SSRIs those are typically the first line of defense. But it may actually, your line of medication may be something more like a mood stabilizing component, or could be something that's, they're even using anticonvulsives in some circumstances that are showing some pretty prominent effect to some of these symptoms. What are some of the general obstacles there's some obstacles to the response to these medications?
Yeah, there really are, because we'd like to get blood levels. You would think we'd be sophisticated enough where we could get a blood level to determine if you've got the right amount in the system, and unfortunately there's not blood levels for these medications that are helpful. There were blood levels for some old medications, but they're really not particularly helpful. You worry about drug interactions that can get in the way of a medication responding. Substance abuse, we always worry about that. Even alcohol, for instance.
You see that a lot? You see
all the time, Rusty.
So people are trying to self-medicate. I mean, it's kind of like the census on that. Would you agree with that?
Yes, in many cases it's self-medication, trying to help. I have so many patients that self-medicate to sleep, self-medicate for mood, with alcohol or other drugs, and it's just a disaster. The medications, antidepressants, don't work well if you're drinking along with them.
Yeah.
And I had one patient not too long ago who I've been treating for years, and he started as a middle-aged man drinking to be able to go to sleep, as he was having trouble sleeping, and he became an alcoholic.
Yeah.
He didn't mean to, didn't try to, and we tried to treat his alcoholism, and he just would not. he would not give up the alcohol. And I recently read his obituary, and I was so saddened to see that he passed away from alcoholism.
So the whole concept behind, self-medication is that a person tries to find something, they do something, use a substance, alcohol, they use drugs to try to make themselves feel comfortable.
That's right. And so part of chemical dependency treatment is to, of course, detox the person from that drug, get them away from the drug, get them involved in AA and coping skills to be able to deal with not using the drugs, but also to look for psychiatric illness, because it may be that if you can treat their depression, their bipolar disorder, or other illnesses or physical illnesses that led to them feeling so badly, that it'd be much, much easier for them to stop using the drugs.
And that takes like more of a broad approach. It's not always medication management, but you may actually start incorporating counseling and start incorporating psychoeducation, kind of a well-rounded approach to try to give these individuals more insight to themselves.
Yeah, absolutely. And we do other things, like I prescribe exercise all the time. And I literally write down on a prescription pad many times, exercise 30 minutes a day, 5 times a week, moderate, walking, aggressive walking or whatever, and have a specific exercise prescription for patients. That also helps.
There's a lot of really strong studies on the outcome of exercise and on depression, and it actually works really well. It's a very, very natural way to kind of manage in a lot of these circumstances. Would you agree?
Oh, absolutely. And I have to give kudos to Dr. Cooper here in Dallas, who has the Cooper Fitness Center, Cooper Institute, Cooper Clinic, all that. He has done more research than anybody in the world on looking at exercise and mood and the positive effects it can have. And he's been a major scientist in helping us understand that.
Yeah, he has an enormous facility too in Dallas.
He does. Yeah, he is kind enough to refer patients to me sometimes. And when I get a call from Dr. Cooper, it's like Mick Jagger's calling me. I get so excited.
He's
it's
the
like,
rock
oh my
star.
God, Dr. Cooper is calling.
That's really amazing. What are the classes of antidepressants?
Well, there are many antidepressants on the market. There's about 25 on the market. And so it's we had the old-timey ones were things called tricyclic antidepressants. There were things like Elavil and Sinequan, Doxepin that aren't used that much now for depression because they had so many side effects to them: dry mouth, constipation, blurred vision, and very dangerous in overdose. We moved into, in 1987, a class called SSRIs, which I heard you refer to before, Rusty, which is selective serotonin reuptake inhibitors. And those are the class like Prozac and Paxil and Zoloft and Lexapro and Celexa, those kind of medications. And they revolutionized because they were so much safer. And I know they came out in November of 1987. And the reason I can always remember that is that's when my anniversary was. And I remember discussions with my wife talking about that right when we got married. And she wanted to be placed on Prozac. And I said, hey, you're not depressed. I mean, no, you're trying to prevent depression with a life for me maybe, but you're not, what do you do? Because everyone thought at that time that these medications were so effective that they had no side effects, help you lose weight, help you be better than your baseline and so forth. Then we learned that was overhyping, but those are a good class. And now we have newer medications still that increase not only serotonin, like the selective serotonin reuptake inhibitors, but increase norepinephrine, increase dopamine along with serotonin. So there's many new medications on the market now.
Yeah, and those dopamines. Well, actually, let's talk about the norepinephrine reuptake inhibitors. You see a lot of that, like in Strattera, like medications for ADHD. How effective are those? I mean, does it have the same effect on appetite as it does a stimulant? Or do you see anything like that?
Well, for ADHD, when you do like Strattera, there's medications that are non-stimulants, and that's a non-stimulant example. They generally are not quite as effective, but they work for some people. They work nicely for some people, so we like to try them because the stimulants can have decreased appetite, as you're saying. You can be abused.
Yeah.
So we want to be real careful with that. So, but they don't generally have the appetite suppressant effect. The non-stimulants don't have, like a Strattera doesn't have the appetite.
So are you seeing less of an effect on that with the with these newer classes of medications? Less effect on less side effects in general?
I'd say there are less side effects in some of these medications, because we always worry about like sexual side effects and weight gain, and some of the newer agents seem to be better in that respect. But any medication, unfortunately, can have some side effects.
Gotcha.
Yeah, and so our goal of treatment, though, what we really want to accomplish is wellness. It's called, this psychiatrists call it remission. What we're looking for is not just improvement, and that's a big issue because a lot of times, people say, "Oh, if I could just be somewhat better, I'd be very happy." But that's not acceptable. We want to be back to our baseline where we're well. It's kind of like if I went to a doctor and said, I have this pain in my side, and when I eat, I get really sick, and they do an evaluation and said, well, I see here on the sonogram you have 4 gallstones. Let me remove 2 of them, and you'll feel somewhat better. Mm-hmm. I'd say, no, please remove all of them and let me feel well. That's what we try to get. Our goal is for patients to get over their depression and to get well.
Gotcha. Can you say something about just the whole topic of depression as we're moving into suicide in the next 2 segments? How could you sum up, what could you say to somebody who is experiencing these types of symptoms, and what would be your recommendation?
Well, I'd say that depression is a very serious matter. It's a real illness. It's a medical illness with some emotional symptoms, some physical symptoms. It needs to be treated. It needs to be aggressively treated. You're not weak if you get treated, and that if you don't treat it, it can lead to diminished quality of life in every aspect of your life, and even to suicide.
And that's that's going to be our next topic, but you certainly don't want to let anything fester to the point that you start to lose major interest in life. And that's where we're going in this next segment. We'll be right back after these messages.
Are you ready for some football? Hello, everybody. I'm Gary Rice, your host of a brand new show starting this Sunday at 6 p.m. called Football Talk. After all, we live in Texas. Join me as we discuss the gridiron game from Pee Wee to the pros. Football's more than just stats. It's a game of strategy as 2 teams try to outwit each other to victory. If you're a coach in youth football, I have a segment just for you that will make you a better coach. Can TCU make it to the Final Four? What about life at Baylor after Art Brown? We'll talk about it. Don't fumble your chance to listen to Football Talk this Sunday at 6 p.m. on the station that knows talk, 1190.
Thousands of people are choosing the flexibility of working when they want, driving with Uber. You'll control your day, plus be able to start earning right away just by driving your own car.
I've got 2 kids. They're both in summer camp, and I'll drop them off. Then I turn on the Uber app, the ride requests come in, and I'm earning extra money. Working when I want, being my own boss. Driving with Uber is definitely the best option for me.
Earn the extra money you need on your schedule. Get started today. Sign up right now. Go to uber.com/drive now. uber.com/drive now.
Hey everyone!
This is Life Tips with Geico.
Life Tip 1. Use a shower squeegee to remove pet fur from carpet.
Squeegee is also very fun to say. Consider it when naming a pet or child.
Life Tip 2. Switch to Geico and you could save hundreds on your car insurance.
With over 75 years of experience and a 97% customer satisfaction rating, they know what they're doing.
Geico. Get savings into your life. Visit geico.com today.
You're unique, so why is your mattress one size fits all? Because a custom mattress costs thousands, until now. Hi, I'm Christian von Rickenbach, founder of HelixSleep.com, where you can buy a mattress online, customized for you, for hundreds of dollars instead of thousands. Go to HelixSleep.com, answer a few simple questions, and we build you the most comfortable mattress you'll ever sleep on. Shipping is free, and you have 100 nights to try it out. Go to HelixSleep.com/sleep and get $50 off your order. HelixSleep.com/sleep.
I want to thank my mommy for loving me so much, for taking me out to the park, for reading me books, for taking me to the doctor when I broke my foot in ballet rehearsal,
for leaving me alone when I wanted to be alone.
And now, as a grown-up, I'm thankful for being able to take care of you, my dear mom, for having the chance to take you to the park, for reading you those books we enjoy so much, for being able to take you to your therapies after you twisted your ankle, for understanding that sometimes you simply want to be alone.
Roles change without us noticing. And in your new role, we help you help. Visit aarp.org/caregiving to get practical health and wellness tips to provide even better care for your loved one. Remember, visit aarp.org/caregiving. AARP. We help you help. A public service announcement brought to you by AARP and the Ad Council.
You're listening to the Therapy Hour with Rusty Lozano, brought to you by the Center for Biofeedback and Behavior Therapy in Addison, Texas.
Hi, and we're back. Thank you for joining us. If you are just joining us, we're visiting with Dr. Joel Holliner from the Holliner Psychiatric Group. And we were just talking about depression, and I was really intrigued. A lot of information. Little cogs are always turning in my head when I hear some interesting information. I'm just kind of stumped. But let's talk about how when an individual experiences depression, there can actually be some degree of like more of a major shift in their mood, major shift in their life circumstances, and circumstances can get very desperate and therefore leading to more suicidal ideation, suicidal tendencies, and suicide itself. Dr. Holliner, can you give us some facts about the correlation between suicide and depression?
Well, we see that it's very common when folks have attempted suicide, obviously that they're depressed. That seems pretty intuitive, but it's very, very true. There's some people say, oh, suicide's just a rational choice that someone can make, and they can decide they're just going to end their life based looking at the pluses and minuses of their life and decide they just want to kill themselves. Mm-hmm. And it's just a rational choice. I don't agree with that because certainly there are situations where that is the case, where someone has a terrible cancer and they're in excruciating pain, and I can be sympathetic to them deciding that they just can't go on like that. I understand that. But the great majority of folks that kill themselves are in the midst of a severe depression. And that's very treatable. Mm-hmm. And it can be turned around.
And in that midst of depression, it clouds their judgment, it clouds their outcome, and they're looking around at the world and they feel helpless. They feel like things aren't getting better, and they aren't going to get better. But they're in the middle of this. They're in the middle of the diagnosis. They're in the middle of the symptoms of depression.
They're totally right, Rusty. They're viewing the world. You heard the term in rose-colored glasses, seeing everything rosy and great. Well, they're viewing the world in gray-colored glasses because everything looks worse than it really is. It doesn't look like there's a way out when there really is. I mean, if you step back and look at it, they're just viewing the world through depressed lenses, and that's what's getting them feeling overwhelmed and hopeless and suicidal.
I refer to this in my own practice. I call it stepping out of the red circle. And when I work with patients that have anxiety and they have pain-related symptoms, you start to develop what's called pain behavior or symptomatic behavior. That is, I can't do this, or I can't go because I have a headache. I can't go because I'm going to get a headache. And so it's all synonymous. It's one and the same. And so when an individual is in the middle of all of their circumstances, and we teach people how to kind of gauge what's going on with their bodies, because something is making them feel uncomfortable, and so then it's affecting how they are seeing the world or how they're feeling. And so the concept is to kind of step out of the red circle, do some things to calm yourself down, do some things to kind of relax the body. Then you feel a little bit better. And then once you kind of realize, oh, I'm really tense right now, and I have a lot of I feel really uncomfortable. Let me calm myself down. And then once you step out of it, you're like, okay, yeah, I feel a little bit better. I can see where I was and how I was thinking because here is where I am.
So it's a way you help them gain insight and make changes. And that's the same thing. If someone's terribly depressed, they can get over this. They can work through it. Therapy, medication, if need be, if it's that bad, hospitalization if they need it for safety. But we can get them through it. And the great majority of patients, no matter how severe their depression is, can do very well with aggressive treatment. But suicide is now an epidemic. There are 35,000 suicides in the United States every year that we know of. I mean, how many of these, you hear about single vehicle accidents, someone crashed into a bridge, someone had this happen, that happened, really might be suicides.
Everything.
We don't know, right? We don't know how many coroners in small towns may say, oh, I don't want to embarrass the family and say it was a suicide, so I'll call it a heart attack or whatever. Yeah. And so it's really not even clear how many suicides there are, but we know it's a terrible problem. There are more suicides in the United States than homicides.
That's amazing.
Yeah. Even with all going on these days, there's still many more suicides than homicides.
Wow.
And, and there's so many patients that attempt suicide, it's just amazing that for every person that dies of suicide, it's called completed suicide is what I call it, and the literature often does that. Sometimes it's called successful suicide. I refuse to use that term, successful suicide, I feel, but completed suicides, there's 30 attempts for every time someone completes a suicide. So it's a big problem. It's actually, when they did a study, they found that 13.5% of Americans have made some sort of suicide attempt at some point in their life. Just an amazing number of people.
That's pretty amazing. Wow, scratching my head.
Yeah, and I was just on a family vacation in California. We were talking about that earlier, Rusty, before the show, and we were passing through Napa Valley and going down into San Francisco, and we went over the Golden Gate Bridge, and I was looking at the rails there because the Golden Gate Bridge is the number one place for people to kill themselves in the world, the Golden Gate Bridge. People jump off that bridge.
Wow.
And I looked, and the rails are still not high. They had little notes in there about suicide crisis hotlines for people to call, but they never built the rails up.
Wow. Yeah. Well, and that, I guess that goes to show that if somebody has a deterministic mindset, that they're gonna do it anyways. I mean, but that's sad. That's very scary.
That's right. And and you would think that as a psychiatrist, I'd have many patients, unfortunately, that would kill themselves, since I'm treating patients that have depressions or severe depressions and hospitalizations a lot of times. But I've had very few suicides in my career. I've had several patients that have killed themselves. It's always been a big surprise to me. I've been stunned. And most patients, or most people, they're not patients, because most people that kill themselves are not in therapy. They're not seeking out help. Those that are, coming in to get help do better, or at least enough of them wants to be around that they're trying to make things better.
Well, that's true. I agree with that. In my own personal experience, I remember I had a former patient commit suicide, and we were talking about that. And several weeks prior to it actually happening, the dad contacted me through text. He goes, "Hey, can you please see my son?" I won't say his name, but he's really spinning off, and so I'd reach out to him, and didn't respond, and so I was making these attempts to reach out to him, say, "Look, I understand if you don't want to come in, but just please let me know you're okay." And then his response was, "I'm fine now. Everything's okay. I'll call you on Monday, and I'll come in and see you." And then I never heard back from him. And then I got a text 3-4 days later that the dad texted me and said he killed himself last night. And I jumped out of bed, and I was just in complete shock. And it started from there, and it really, but he wasn't in treatment, and we were trying to get him in to get him stabilized. And I talked to the dad. I was like, "Look, he needs to be hospitalized if he's out of control." And they couldn't reach him at that point. He was 22. And so he wasn't in the house, and he was living on his own. But yeah, that's how those things happen. And I'm sure you've had your experiences with, circumstances like that as well. And it's very sad, and it makes you question everything as a professional. I mean, it makes you think about what you could have done better, and was it my fault? And really difficult thing to compute. At that particular circumstance. So, but there are certainly things that can be done, and I'm glad that we're talking about this because somebody out there today is hearing this message that there are things that can be done.
Absolutely. And as terrible as it is for the therapist and the psychiatrist, you can only imagine what it's like for the family members, the loved ones, the friends, the girlfriend that broke up, with them and then feels responsible, and it's terrible, and it leaves a legacy in the family to make it easier for other relatives when they're facing a difficult time to think of suicide as an option. And I tell parents all the time that are suicidal and actively suicidal, I said, "Do you love your children?" Of course, everyone loves their children, so I know the answer to that. Yeah. And they said, "Yeah, of course I do." And I said, "Well, if you were to kill yourself, it'd make it much more likely that your child would kill themselves at some point in their life." And that's, I think, made a difference for some.
Oh, gosh, that'd make a tremendous difference because I think that then there's some awareness, there's mindfulness at that point that, it's not all about me, and it's not all about just my circumstances, but there are other people involved. And I've even heard people say, well, think about like the people you're going to hurt. And then somebody's comment to that was, well, that's a pretty narcissistic way of thinking. This is about me, not about them. And then I was like, what? And so I had to kind of contemplate that a little bit also, but really interesting. Tell me a little bit more about some facts before we get into military.
Well, I'd say spring is the most common
season
for suicide. I don't think it has anything to do with taxes being due. I guess you never know. But spring, I kind of view it. My theory is that in the winter, maybe people are kind of maybe more down and
holidays, right?
And the holidays maybe didn't go as well as they had hoped, or wasn't as warm and Norman Rockwell-ish as they'd hoped it would be. And then when the spring comes, there's more energy, and they see people out more and seem to be happier, and they're not. And that they may be more likely to say, okay, they see the contrast between the way they want the world to be and the way the world is for them. Also you mentioned about going to therapists and doctors, but it's very common that patients that are suicidal go to their medical doctors. And it's found that 75% have been to their medical doctor within a month prior to them killing themselves. 40% have been in with a week, and 20% were in that day.
So that's an immediate resource. You don't have to reinvent the wheel. You just go to your doc. Right away and
go to your doc, but tell them what's going on, because these are folks that went to their doctor and didn't tell them they were suicidal.
Amazing. Well, we're going to take a quick commercial break. We'll be right back after these messages.
Have you ever considered weight loss surgery? At Faith Bariatric Success Center, they can help. If you've ever thought about weight loss surgery, call pound 250 from Eddie's cell phone and say Faith Bariatric to get more information. Now offering free consultations. Pound 250 and say Faith Bariatric.
You're unique, so why is your mattress one size fits all? Because a custom mattress costs thousands, until now. Hi, I'm Christian von Rickenbach, founder of HelixSleep.com, where you can buy a mattress online, customized for you, for hundreds of dollars instead of thousands. Go to HelixSleep.com, answer a few simple questions, and we build you the most comfortable mattress you'll ever sleep on. Shipping is free, and you have 100 nights to try it out. Go to HelixSleep.com/sleep and get $50 off your order. HelixSleep.com/sleep.
Do you think identity theft is only when someone adds charges to your credit card? It's actually when someone pretends to be you to open new accounts in your name or any number of bad things. LifeLock can help. We use proprietary technology to alert you to a huge range of identity threats. And if you have a problem, we have a team of U.S.-based specialists who will work to fix it. No one can prevent all identity theft or monitor all transactions at all businesses. Membership starts at $9.99 a month, plus applicable taxes. Go to LifeLock.com and use promo code NEWS to get 10% off.
From the Talk Radio 1190 Weather Center, this report is brought to you by Key Whitman Eye Center. Today, it looks like we're going to have partly cloudy skies with a high around 102 and a 20% chance of rain, but I doubt that happens. And tonight, clear skies with a low around 82. I'm Will Shotwell with your DFW weather.
Tired of contacts and glasses? Right now, LASIK is a hot $99 a month and you get $1,200 off. Only at Key Whitman for a limited time. So call now, 214-220-EYES, or visit keywhitman.com.
You're listening to the Therapy Hour with Rusty Lozano, brought to you by the Center for Biofeedback and Behavior Therapy in Addison, Texas.
Hi, we're back. We were visiting with Joel Holliner, and we just left a segment where we were discussing suicide. We started out talking about depression, and now we're talking about suicide. Let's talk about military suicide. This seems to be a topic of major interest these days. With organizations like 22 Kill that I was telling you about earlier, where it's an organization that actually will, they estimate that there's 22 suicide deaths per day with these soldiers coming back with PTSD. And so they're a resource for these individuals coming back from service time to debrief and get the right kind of help so that they can live a good quality of life. What are the statistics on military suicides, Doc?
Well, military suicide it's in crisis mode right now. There's so many military suicides, and the government is panicked about it. It's a big political issue right now at the campaigns, but also it's been a real embarrassment for the VA system. They've done everything they can to help with it. It's increased 80%. Military suicides have been 80% over the last couple of years.
Jeez.
The last year, where they really put all this energy and money and resources into it, increased 18% again. The military spends $2 billion a year to combat military suicide. At $2 billion a year,
amazing.
And it's doing nothing but increasing.
Can't figure it out.
And it's the PTSD, it's all these different deployments. But, it's not just that, Rusty, because they found that a third of the military suicides are soldiers that have never been deployed.
Really?
And another, yeah, absolutely. And 43% of them have only had one deployment. So it's not totally that they've been deployed over and over and over, which we hear about the fatigue and the PTSD that comes about from these multiple deployments and being away from their families and so forth. But there's something else going on. I don't know if it has something to do with it. Since it's a volunteer army, are we getting a higher percentage of folks in there that are more unstable?
Yeah, right.
Than they would.
Started out kind of a little bit more unstable.
Maybe they're choosing that because they've gotten into trouble in other ways. Maybe that's a factor. I think another thing is that these soldiers I see over and over in my practice, they come back and they are underemployed, or have trouble getting jobs, or do have PTSD, and that's been a challenge. So there's a lot of stressors. I think we need to really work with these great organizations that help with PTSD and work to guarantee. I think that the government put $2 billion. They could put a piece of that to guarantee that every soldier that comes back has a job. We've got plenty of jobs in this country that need to be going. Infrastructure problems or whatever, however we want to deal with it. And every soldier that comes back has an opportunity to be productive and have a job, because that transition back is tough.
Reacclimating into civilian life and civilian mode. But yeah, that would be just one less worry.
Absolutely.
Because now the paychecks stop coming now that you're not active. And then also you're coming back here with an influenced experience that now you're projecting onto this environment, and there was an actuation. You would have these battles, and I guess you would interact or have engaged the enemy. Here, there's no actuation, so they're consistently filtering, looking around for where's the trouble, and I can only imagine that could get overwhelming. And how do you desensitize that? How do you shut it down?
It is such a challenge, and the VA is doing everything they can to help it, and they're overflowing to private doctors. And I've gotten to see quite a number of guys with PTSD, and you treat it with therapy and medications, and all kinds of cognitive therapies, behavioral therapies. You expose them to different stimuli that remind them of things that were like war, and help them get over it and realize it's not that way now. But they're sitting in the corners of restaurants, making sure they see everything going on in the restaurant. Every place they're going, they're looking around, being careful, and that sort of thing. And the military suicides, 2/3 of them, as probably could be expected, are from gunshot wounds.
Really?
And we know that firearms are the number one lethal way to kill yourself. And it's really a challenge in the country because we have all these debates about what do we do with firearms and safety and so forth. And I would say I'm not trying to get in the middle of that, Second Amendment argument.
Debate,
but if you have a loved one who is very depressed, I personally do not think they should have a firearm in their house, particularly if they've had suicidal thoughts. That's one of the things we do in the hospitals. We take, if someone comes to the hospital and is depressed, and particularly if they're suicidal, we make sure that the firearms are out of their house during the period of time when they're depressed and suicidal, because the risk is so high, much higher, that they would use it on themselves than they would use it to protect their home in general.
Mm-hmm.
The Israeli military had a problem. A few years back, there was a crisis that they had a rash of suicides in the Israeli military. They'd go off to battle, see something traumatic, come home, and they'd have a weekend off. And their weekends off, they were having suicide after suicide. Wow. What they realized is that they were using their rifles, because they had the rifles with them. So they made a new policy that on the weekends off, they kept their rifles there at the base and didn't take it home, and the suicide rate plummeted. And it did not go up by any other means.
Yeah, interesting.
So the firearm issue is a challenge.
And I
what
think
to
that,
do.
If somebody did have firearms and they're not open to just getting rid of them, that maybe there's a compromise. Well, let's put the ammunition. We'll lock it away over here. Excuse me. We'll lock it away over here so it's not accessible. And if you need it, then then we'll go and get it. And so at least having that separation, putting a separation between just a full-on actuation and stumping that process. And
Absolutely.
Yeah. What are the male to female ratios of suicide?
Oh, well, suicide's far more common in men than women. Now, women attempt suicide much more often, but the way they attempt suicide is not so much with firearms. It's maybe cutting their wrist or taking an overdose or things that certainly could kill you but aren't as likely to kill you as using firearms or hanging or jumping off, a building or something. Men are more aggressive by nature,
right,
and try to kill themselves in more aggressive ways. So it's much more common. Completed suicides are much more common in males. They increase as we age, and so elderly males have the highest risk.
Really?
Of suicide. Absolutely. Particularly if you have chronic illness,
yeah,
if you have pain, greatly increases your risk. Something that will save you, though, and help decrease risk is if you're married, if you're employed, if you're connected to a religious group, if you have children, if you're part of a network and feel involved, that makes it less likely that you'd kill yourself.
Interesting, because you have other resources, you have other things that you can actually spend your time with and distract you, or even like call in for help. Outside influences to help you kind of get change the mindset. Get a little bit more
that,
stabilized.
and also have a reason to be around. I can't tell you how many patients I've had that have been actively suicidal and told me that I would kill myself if it weren't for my cat or my dog or my parakeet that needs me, and I have to be there for them to take care of them. And that's the only reason that kept them from not killing themselves.
Interesting. Wow. Yeah, because there's a feeling of being needed. Correct.
That's right. To be needed and be involved and have someone that loves you or that someone that you love or something you love to take care of and care about.
Interesting. Really, really fascinating stuff. What about adolescent suicide?
Well, adolescent suicide is becoming more and more of a problem now, too. And we see it in all adolescents, but particularly those that get bullied or involved in cyberbullying.
Seeing a lot of that these days.
Oh, it is terrible. It's thought that 20 to 30% of those that get bullied have suicidal thoughts.
Did you hear about that YouTube video of the little girl who made a video of herself where she has these papers and it talks about, a little sheet at a time and it tells a story and it's written really big?
No, I haven't.
And then by the end it says, well, by the time, somebody asks about all this, I'll be gone. And it was like her goodbye video that she posted. And she committed suicide and she told the story about being bullied. She told the story about how she was having difficulty adjusting, and it went viral, majorly viral. And yeah, it was really disturbing, because she's cute, and it looked like, the music you wouldn't expect like what the message was behind like the whole entire purpose of that video, but it's out there and it happens, and these kids are experiencing it.
And they've also found that, of course, getting bullied increases depression and suicidality, but those that bully also have more depression and more suicidality. So it's not just the victims, it's the perpetrators also. And if you look in the LBGT community, 90% of them get bullied, 90%, and then many of those have suicidal thoughts. And I just say for families that are struggling with their kids, sexuality, and if they have a child that's gay and they're thinking, oh, well, I'm going to change you, or I'm not accepting this, it's not okay. We find that there's an 8-fold increase in suicide. So I think for parents, no matter what your religious beliefs are, and I think you really need to step back and say, I love my child, and I don't want them to kill themselves, and I better accept them.
Yeah, I think that's really important. And I do see a few patients like that at my own office where, he got away from that home environment. He's living with the aunt, but the father still has a really difficult time accepting him, and the aunt is very, very accepting. So it's it does happen, and it's and I'm one office, and I imagine that there's probably several others that are out there that work with patients like this, and it's very, very difficult for them. Very, very sad. Well, Dr. Holliner, how can people find you? How can you be reached? And if somebody's experiencing depression, when should they call?
Well, I think they should call. They could see their family doctor, certainly. But if they continue to have problems, they definitely need to call the office sooner rather than later. Let's jump on this. Let's do an evaluation, see what they need, whether it's therapy, medication, whatever it is. And my office number is 972-566-4591, and I'm at Medical City Dallas Hospital.
And Medical City it's a huge mecca of specialists, and definitely seek some help and don't try to handle this yourself. Lots of resources out there. Well, thank you so much for being on the show. I really appreciate it. It's very insightful. I want to make an announcement. The show is going to take a hiatus until October 1st. I'm going to get my kids back into school and back into the routine for the year. So we will be back October 1st. If you would like more information about our clinic, please go to my website at cbbt.org or my YouTube station at Rusty Lozano. You can actually listen to any one of these shows. You can follow me on Twitter at Center for Biofeedback or Rusty Lozano. And I really do appreciate you coming in, and have a blessed day.